Hi Arunima, I'm trying the audio again. Can you hear me?
Yes.
Okay, cool. Thank you.
We'll just give a time for people to join. So, Tiara has shut up joined yet?
He said he'll join soon.
Okay, that's fine.
Hello, everybody. Can you hear me? Morning.
Hello, Shadab. Very good morning to you.
Yes, morning.
Thank you for joining. And thank Dr. Sigi and also Dr. Bishnu to be here with us today. Perhaps Dr. Soman will start in a minute now that participants are slowly more and more joining in.
Yeah, sure.
Thank you. Okay, perhaps we can start now.
Right. Thank you, Pauline. Good morning, good afternoon, everyone. I am Suman Rijal. I'm the Director of the Communicable Disease Department at WHO Regional Office for Southeast Asia, based here in Delhi. Colleagues, participants from the Ministry of Health, public health professionals, clinicians, health facility staff, communities, civil society organizations, partners, and my WHO colleagues. I'd like to welcome you to this WHO SEARO webinar in collaboration with the project ECOF. We gather here to commemorate the World Hepatitis Day that was actually on 20th of July. This is a momentous occasion dedicated to raise awareness of the hepatitis impact and to call for actions to address this global public health challenge. This year's theme is Time for Action. This theme emphasizes that the progress on elimination of viral hepatitis as a public health problem has stalled, and that we need to accelerate actions, and get back on track towards elimination by 2030. Viral hepatitis is the 7th leading cause of mortality worldwide and is the only communicable disease for which mortality is increasing. In fact, deaths due to viral hepatitis increased from 1.1 million in 2019 to 1.3 million in 2022. These rising deaths are due to hepatitis-related liver cirrhosis and cancer deaths. Untreated, both hepatitis B and C infection causes progressive damage to the liver, leading to cirrhosis and much elevated risks of liver cancer. Viral hepatitis is preventable and can be treated. However, in the Southeast Asia region, less than 5% of the people living with hepatitis B have been diagnosed and received treatment. In people living with hepatitis C, 26% have been diagnosed and 14% have received treatment. Our focus today for this seminar will be to raise the awareness on viral hepatitis infections and its impact, and to raise awareness on liver cancer burden globally and in the Southeast Asia region, and its link to hepatitis B virus and the hepatitis C virus infection. Furthermore, the webinar will also highlight the urgency of taking action in scaling up access to prevention, test, and treatment, and addressing stigma and discrimination towards people living with hepatitis B and C. We will also be listening to the lived experience of hepatitis survivor and taking on this message moving forward. I do hope you will benefit and also enjoy the webinar. And with these few words, I once again welcome all of you today. Now, moving forward, I would like to invite Dr. Pauline Chan, the Regional Advisor for Hepatitis, HIV, and STI, WHO SEARO, to facilitate this webinar and also to make a presentation of the hepatitis B and C burden in the Southeast Asia region. Over to you, Pauline.
Thank you very much, Dr. Suman Rijal, and it's my pleasure to be here today. We have an exciting lineup today to talk about, with my other colleagues, to talk about vaccination in the region and also about liver cancer as well. But first, to set the scene, I will present you on the overall updates around hepatitis B and C in the region. May I have my slide, please? Thank you. So thank you for your attention. We have new data as of April of this year, where WHO has now released the global hepatitis report since April of 2024. And for the first time, more than 150 countries have reported on the hepatitis picture of B and C. So there are updated estimates which show that globally, in total, there are over 304 million people living with hepatitis B and C. The majority, hepatitis B, is around 274 million, and hepatitis C is around 15 million. Prevalence of B and C is varied across the region and across countries. So in SEARO, next slide, please. Next slide, please. Yes, thank you. So in the Southeast Asia region, we have a total of 70.4 million people. The predominant is still hepatitis B at 61.4 million people, and hepatitis C totals around 9.1 million. Now, overall prevalence of hepatitis B among adults in the Southeast Asia region is around an average of 3%, with a lot of country diversity. It ranges from 1% to almost 9 to 10% in several countries. And in hepatitis C, overall, the prevalence is less than 1%, but even with less than 1% in countries, that translates to quite a lot of thousands, or 100,000s and millions in a few of the more populous countries as well. So we have quite a lot of work to do. The good news is vaccination has brought down the overall hepatitis B prevalence among children younger than 5 years because of universal free childhood immunization, and for the region is around 0.4%. New hepatitis infections are occurring for many reasons, so transmission is happening still in many countries or many settings, and in some specific groups, including migrants and refugees, which bear quite a high burden of hepatitis B. Deaths are being caused by hepatitis B and C, mainly from liver cirrhosis, liver cancer, and hepatic failure when it is untreated or left to a very late stage. Very importantly, next. You click. Very importantly, no, the one before. Thank you. Very importantly, the percentage of people living with hepatitis B and C who are diagnosed still remain quite low. We are doing better with hepatitis C, but still only 26% is diagnosed and only 14% is treated. But for hepatitis B, there's still a lot of work to do because less than 3% are diagnosed and less than 3% receive treatment of those diagnosed. Next. So let's look forwards towards 2030, towards the achievement of the Sustainable Development Goals. What we see, and these are studies from modeling, that today, based on the latest data that we have in WHO, the overall prevalence of us in the Southeast Asia region, the prevalence is gradually reducing for hepatitis B. The new chronic infections are also reducing because we are reducing the numbers of babies that are infected with hepatitis B. But hepatitis C cancer, hepatitis B and C cancer, liver cancer is increasing gradually, and it will peak after 2030. With the data that we have today, liver-related deaths due to cirrhosis and due to decompensated cirrhosis is also increasing. So the trajectory of mortality is actually increasing, and it will also increase beyond 2030. Next slide. About hepatitis C. Now, hepatitis C is quite important because this is the hepatitis epidemic that we have a cure. And this cure cost around US $60 in general. And that's for the lowest cost of a drug. And it can be, hepatitis C can be cured in just 3 months of drugs. So what do we see in the impact in this region? The viremic hepatitis C infection is static. What it tells us is that we still have a lot of millions of people living with hepatitis C, but we are not finding them, we're not treating them fast enough. And that's one of the reasons why the viremic hepatitis C infection, which is a prevalence, is still very static. And this is the top left hand corner graph. New chronic infections are also static. This is the bottom left-hand graph, because we are not finding people and not treating them. Liver cancer, in that sense, because the burden is so high, and liver-related death will increase because of this. So essentially, the message from here is that we have to test and we have to treat people when we find them, so that we can reduce the numbers of people living who are dying from hepatitis C. And in that way, also reduce the number of chronic infections and reduce the number of viremic hepatitis C infection. Next slide. So it's not just about liver cancer or the death from liver cancer. We are very concerned now is, and this is what the information has shown with the update of data, is that there is a global burden of cirrhosis. There are, in fact, more people living with cirrhosis than with liver cancer. And hepatitis B and hepatitis C accounts for 2/3 of the global burden of cirrhosis. In the Southeast Asia region, and that red arrow there points towards the Southeast Asia region, the hepatitis B and C are half and half. So the cirrhosis in the SEARO region is due to both roughly proportional hepatitis B and hepatitis C. And this is quite important because we have treatment for hepatitis B and a cure for hepatitis C. Next slide. And when people start with treatment, the cirrhosis somewhat will be reversed. And that is quite important to catch people who are living with hepatitis B and C early, so that the cirrhosis doesn't further progress. And I would like to point out this, and you might see this in the slide deck of Dr. Bishnu Giri, our cancer expert, that liver cancer in SEARO is an invisible epidemic. And it's quite important because liver cancer is projected to increase given the demographic shift towards and more aging population beyond 2030. We will need to address more preventable liver cancer and the infective cause. And here I want to show that the top few countries include Thailand and Myanmar and Indonesia, and these are also and also in the Democratic Republic of Korea, where the country has a very large burden of liver cancer. Once detected liver cancer, the survival is quite poor. Next slide. Now, turning back to really the testing and treatment and why it matters. In the Southeast Asia region, our hepatitis B cascade of care is not so good. There's still a lot of work to do. Of the estimated 60.1 million people living with hepatitis B, we expect around 33% to, we expect some part of them to be eligible for treatment, but diagnosed is only around 3%, and getting into care and treated is even less. So the more important thing is, while we test, we also need to link them to care staging of the liver disease, getting them into treatment, but also, very importantly, retention, making sure that patients who are on hepatitis B drugs actually come back for follow-up and continue to maintain their treatment and taking of medications. Next slide. In hepatitis C, the Southeast Asia region boasts of countries that have production capacity. That means that for most of the countries in the Southeast Asia, drugs are produced inside this region. And India is a very big manufacturing base for generics, which are really affordable. So most countries already have fairly affordable drugs in their formulary. And hepatitis C is easy to take. It's 1 pill a day for 12 weeks. And most people who take it will be cured. So the cure rate is around 95%. But very importantly is in this region, this cascade of care shows that of the almost 9 million people who are infected, diagnosed is around 26%, around very much less. We have treated less as well, but the SVR is very high. Next slide. So I want to also let you know that this year was also critical because we updated the guidelines for prevention, diagnosis, and care and treatment for people with hepatitis B infection. And this is the QR code where it leads you to the new 2024 hepatitis B treatment guidelines and policy briefs. Next slide. There are quite important updates in the new hepatitis B guidelines from WHO because this is a very important update almost after 1 decade. The last time we have the first ever hepatitis B guidelines was in 2015 with a update in 2020 for use of antiviral drugs in pregnant women. So there are 6 areas, the key areas for the new hepatitis B guidelines, ranging and most importantly about who to treat. Who to treat actually expands a lot the treatment eligibility for clinicians. Next slide, please. So in 2015, we had the original algorithm and protocol for treatment. And in 2024, the new protocol includes quite a lot of flexibility on eligibility of treatment. And very importantly, expands really to include pregnant women, adolescent children, and women of reproductive age, so that many more people can get treatment. Next slide. There are a few key approaches that we in WHO recommend for service delivery for a public health response, including strengthening linkage from testing to care and treatment. Countries need to try to use strategies to promote and sustain long-term adherence to treatment, including using peer counselors, text reminders, adherence. There are also strategies to promote retention in care, family support, buddies to help with long-term treatment and chronic treatment, integration of treatment services, making sure that hepatitis B and C testing and treatment services are decentralized to primary care facilities and not just only delivered by specialists. So in many countries, GPs are delivering hepatitis B testing, confirmation, and treatment. And then referring up for more complex issues. There's task sharing and community engagement as well. Next slide. So a couple of the key message is that the first is for people who are listening in, who are more lay people, And really, I would encourage anyone to be here to disseminate to people in the public and families to say, speak to your doctor, get a blood test, because hepatitis B is manageable. There is drugs for this, and hepatitis C has very effective drugs that can cure the infection. And if people are pregnant or planning pregnancy or going to have babies, is to take the blood test during pregnancy and have vaccination for your babies. For program managers is to update the national guidelines with the new WHO guidelines if countries haven't done that yet. Conduct capacity building for healthcare workers. Training is really important because we need all update of information and knowledge. And to scale up testing and case finding and treatment. And at the end, to reduce the risk of development of liver cancer. And lastly, to explore opportunities to reduce prices for hepatitis products. For communities that are listening into this webinar, support planning. Be part of the project or the program cycle of planning at the national and the subnational level. Work on demand generation, on case finding and linking people into care. And also to help us advocate and communicate on treatment literacy and help us to break the stigma and discrimination. Next. I'd like to acknowledge my team and the WHO SEARO 11 country officers. They are the forefront of this combat on hepatitis and to help countries work towards elimination of viral hepatitis as a public health threat by 2030, and also especially to the ECHO team India. Today, we stand in Hepatitis Day 2024 with the slogan of "It's time for action," and truly, we have to test, treat, prevent hepatitis, and try to get things done. We welcome all to join us in this effort to get to preventing liver cancer and treating and eliminating hepatitis. Thank you. So we will now move on quickly to Dr. Bishnu Giri, who will talk to us about liver cancer in the Southeast Asia region. Dr. Bishnu is the Technical Officer of Cancer Control of the WHO SEARO region. Over to you, Bishnu.
Thank you, Dr. Pauline. I hope I'm audible and my screen is visible.
Yes, very much. Thank you.
Thank you. I'll be very brief, and the purpose of my presentation, as already mentioned by Dr. Pauline, is to touch briefly on the burden of liver cancer in the Southeast Asia region and to highlight that it is an emerging problem and one of the major concerns within the cancers as well, not just for hepatitis. Globally, in 2022, there were approximately 900,000 cases of liver cancer. And this is the 6th most common cause of cancer globally in terms of numbers. And it caused about 760,000 deaths. And in terms of death, it's the 3rd most common cause of cancer death in the world. The graph on the right-hand side shows the same figure, but in terms of age standardized rates, even then it ranks as the 8th leading cause in terms of incidence, and in terms of mortality, it's the 3rd leading cause, 4th leading cause in terms of ASR. This graph is, the graph on the left-hand side is the same as the one we saw globally, but this is now for Southeast Asia region. The graph on the left-hand side shows liver cancer in terms of age standardized rate as the 8th leading cause of incidence. And in terms of mortality, it's still very high. It's 4th. On the right-hand side, this is more interesting. The curve on the right-hand side is about the projection. How is liver cancer going to be in the next few decades to come? As we see, the upper one, the graph in the blue, is for male and the one below is for female. The number of liver cancer in both male and female is estimated to be double by 2050. So there is a significant rise of liver cancer anticipated in our region in the coming decades. And the question is, are we prepared to handle it? Are we prepared to deal with it? Again, the burden in Southeast Asia region in terms of absolute numbers, in 2022, there were about 107,000 new cases and 103,000 deaths. In terms of number, in our region, it's the 7th leading cause of cancer. And in terms of death, it is the 4th leading cause of cancer death in the Southeast Asia region. Some more interesting fact is that if we look only at the males, liver and intrahepatic biliary duct cancer constitute the 2nd most common cause of cancer death in our region. So liver cancer is emerging really as a huge problem. And when we look at individual country-wise data, we see that there are about some of the countries, top 5 leading cause in 6 countries. Liver cancer is in the top 5 most common cause in 6 countries. And if we look at this figure only in the males, it's common in 8 countries. It's within top 5 causes in the 8 countries. As already presented by Dr. Polin, Thailand, DPR Korea, Myanmar, Indonesia, Timor-Leste, and Maldives, they all have liver cancer as their significant cancer burden in the country. Just to quickly touch upon the etiology of liver cancer, up to 75% of the liver cancer are attributable to hepatitis B and C. And this is true for the developing part of the world, including our region. In our region, almost 2 of the 3 liver cancers are caused by hepatitis B. And up to 17% of all liver cancers can be avoided by stopping alcohol consumption. That's the 2nd most common contributor to liver cancer. Aflatoxins, as we all know from the contaminated food, it contributes to causation of liver cancer. Liver cirrhosis is an independent risk factor for liver cancer, and non-alcoholic steatohepatitis also leads to liver cirrhosis and contributes to liver cancer. Tobacco smoking, among multiple cancer that it causes, it also can lead to liver cancer. And type 2 diabetes and obesity increase the risk. One important point that I want to emphasize in this slide is that the main cause for liver cancer is hepatitis B and C, chronic infection with hepatitis B and C. All other factors that are listed here, if they are coexisting with chronic hepatitis, the risk of liver cancer increases manifold, including co-infection with other hepatitis viruses. On the treatment, again, we have seen this graph again, and I have not used the graph for actual treatment, but I have used the graph for projection because it shows something very interesting here. In treatment, there are multiple modalities of treating liver cancer. That will include surgery. There are chemotherapeutic options, including immunotherapy and targeted therapy. There are some intervention radiological procedures, such as embolization. There can be radiation therapy also. So there are multiple modalities of treatment, but the point is they don't work very well. That's why I have not included anything in the slide. Whereas the graph that I have shared, there are 2 lines for both males and females. The line on the top, which is a continuous line, shows the incidence of liver cancer, whereas the line immediately below each of these 2 lines for male and female, the dotted line, shows the mortality. So you can see that incidence and mortality are almost equal, which means that treatment practically does not work. So the key here is prevention. And that is the most important message that we would like to give today. that if we want to reduce the mortality from liver cancer has to be prevented. Treatment practically does not work. And the key message is that liver cancer is emerging as a leading cause of cancer burden in our region, and hepatitis B and C are the most important contributor in our region. Treatment of liver cancer is generally not effective, so prevention has to be emphasized, and prevention is achievable through effective hepatitis B vaccination, treatment of hepatitis B and C, and avoiding consumption of alcohol and tobacco. That's all from me for today. Thank you. Over to you, Dr. Pauline.
Thank you very much, Dr. Vishnu. And you have brought in a very key, clear messaging that, once people develop liver cancer, it's often too late. It's a really late diagnosis. So the best thing here is really to prevent, and the prevention really is to take care of the infective causes of liver cancer, and also to stop the other concurrent risk factors such as alcohol and smoking. So thank you. We'll address more questions from the public later on. And we'll segue now to the importance of, as they say, turning off the tap of new infections. And I would like to invite Dr. Sigrun Russell, who is our expert in resident for vaccination and in hepatitis B. Over to you, Dr. Sigrun.
Thank you very much, Dr. Pauline, and warm welcome from the immunization team to the participants in this webinar. We really appreciate that we have a chance to talk about the importance of hepatitis B vaccination. It's a universal, beautiful way of ensuring that no newborn baby will be chronically infected. And I would like to not only provide some of the background of the vaccination itself, but then give an idea about what countries in the region have achieved and where we can further improve. Next slide, please. So we know that hepatitis B vaccines that are currently available are inexpensive, they are effective, and they have an excellent safety profile. That is important for everybody who gets vaccinated with them. We can go back, please. Yeah. And we know that the completed vaccine series induces immunity in more than 95% of people that got vaccinated. The protection lasts for at least 20 years. It's possibly lifelong. Now, the key factor is that the vaccine needs to be given, the first dose needs to be given as soon as possible after birth, because the risk of developing chronic infection, can you please go back, is highest among children. It is 80 to 90% if a baby is infected during the first year of life, and then it goes down to 30% if infected before 6 years of age, and it's relatively low in persons affected later in life, meaning healthy adults. Next slide. Who's moving the slides? Okay, fine. So we see very clearly here this graphic presentation, how the risk, the chance of chronic infections decreases in later childhood and in adulthood. And as such, we can never emphasize enough that the birth dose is key, and it is ideally given within 24 hours. Next slide. Next slide, please. Now, what is the hepatitis B vaccine? Well, it contains a viral protein, the surface antigen. It was originally produced from plasma of persons with chronic infection, but now we're using only recombinant vaccine, and it is for intramuscular injection. It has been in use for many years, decades now, which is another testimony of its safety profile. But what's also very interesting, it is relatively stable if it is stored at warmer temperatures. So that means it allows us under certain conditions to even take it out of the cold chain, in which vaccines normally need to be kept at a temperature range of 2 to 8 degrees. However, it needs to be kept in mind it's very sensitive to freezing. And why do I mention that? If the birth dose is given at the place where deliveries takes place, in the delivery ward or clinics, it is highly important that the staff who primarily have the responsibility of getting the baby safety into the world know about this cold chain management aspect. Next slide, please. Now, we have certain schedules for adults and infants or children, particularly for babies. It's either the birth dose followed by 2 or by 3 doses. That's up to countries to decide. And most of the time, and particularly in our region, it is given as a combination vaccine, meaning the doses after the birth dose, and that we call the pentavalent vaccine because it also protects against pertussis, diphtheria, tetanus, and HIB. Now, we, from a public health point of view, recommend to put the focus of the immunization program on the birth dose as well as the doses in infancy, and then later on young children, if they have missed doses that they were supposed to get, it could be done in catch-up immunization. And only if a national program has then additional resources, we recommend vaccination for adults, and we focus this on high-risk groups as defined in the country. One particular high-risk group would be healthcare workers. Next slide. Now, after 3 doses, we have this very high level of protection. It is just for the pediatricians, it needs to be kept in mind that sometimes preterm infants below 2 kg may have a less successful immune response. Next slide. We also need to keep in mind that if older adults or adults have been vaccinated, there could be a lower response rate if they are over 40 years of age. There's obesity, smoking, or chronic systemic illnesses in place, so that has to be kept in mind. But normally, the seroconversion rate, even in older age groups, are high, and most non-responders would respond to an additional 3-dose series. Particular attention needs to be given to immunocompromised individuals or those patients listed here. Once more, the immune response here may be a little bit reduced. Very important, the vaccine can be safely administered to pregnant and lactating women. Next slide. People are often concerned that vaccinations may result in adverse events, as we call them, AFIs, adverse events following immunization. But you will see here that for mild AFIs, which could be pain and a fever, the numbers are in the range as for most other childhood vaccines that we are giving. And for severe reactions, meaning anaphylaxis, it is 1.1 occurrence per million doses given. But that one can be even prevented by doing a proper evaluation of the patient to be vaccinated, and particularly the birth dose would be very unlikely to lead to anaphylaxis because the baby had no exposure to the vaccine components yet. Next slide. Now, how we are doing as a region. You can see here in the blue, dark blue line, the 3 doses, the hepatitis B birth dose coverage for all the 11 countries in the region, and in the light blue line for 3 doses of vaccination in infancy. So there was only a gradual uptake in the early 2000s that was mainly related to the vaccine supply not yet affordable for all countries, but then support mechanisms, particularly through Gavi, the Vaccine Alliance, became available, and then the uptake was good, and then for the past 10 years has been around the 90%, which we require as a minimum for a successful program. The uptake of the birth dose was much lower, and there are reasons for it that I will discuss in a minute. And then you see here these dips in the red box, and that was caused by the pandemic. However, the coverage since then has recovered and has last year been again at 90% for 3 doses and maintained the same 57% for the birth dose. We need to keep in mind, though, that the birth dose, of course, cannot have catch-up vaccination like the other doses at a later age. Now, behind these overall regional coverage figures, next slide, we see, though, quite a bit of variance in countries, and I have used the traffic light scorecard here to highlight where we have a very high coverage, but where we have an intermediate coverage, meaning below 90%, above 80% still, and those countries that have below 80%. And so we see here that more efforts are being required, particularly in Indonesia and in Myanmar. DPR Korea had long vaccine outages due to the pandemic border closure. So once the supplies are there, they will catch up. And for the birth dose, we have still quite a suboptimal picture, and even a country like India here could do better. Now, the countries with very high coverage, they have already been verified as having achieved the control target, which is equal or less than 1% surface antigen in children, and the 6 countries are listed here. Next slide. Now, what are some of the issues with the timely birth dose? Well, I mentioned already that it needs to be given ideally within 24 hours. It still can have some impact if given a little bit later, but after 7 days, it is really not making so much of a difference anymore. It is also important to understand that it can be given safely to premature babies, low birth weight babies, mothers or infants with an HIV infection, or if the baby has jaundice. I'm mentioning this because some of this influences the low coverage that we see in some places. Next slide. So the challenges are particularly home deliveries without skilled birth attendants, where the mother gives birth, in her home together with family members, and healthcare workers do not even yet know that the baby has been born. So the timely application of the birth dose is difficult. But there's also often a lack of awareness or training among health staff at birthing facilities, due to an incomplete integration, for example, in a newborn care package, or false contraindications, the fear of adverse events, and maybe not the best coordination with the mother and child health, as well as the immunization programs. Sometimes it's the vaccine supplies, the availability, especially also if it's multi-dose vials. Healthcare workers may be hesitant to open the vial for only one baby, and such policies like keeping vaccine vial open in usage for a while under certain conditions may not yet be fully appreciated. Availability of cold chain equipment, its proper management can be a challenge, and the incomplete participation of the private sector. Next slide. So what are some of our tools that we have to improve the coverage with the timely birth dose? It's first of all, do very good monitoring through various evaluation mechanisms and identify the causes behind low coverage, and then work together with the respective healthcare teams to address them. Do good communication for decision makers, of politicians to allocate the budget, for the health workers as well as parents and community. Have a strong coordination between the different programs, immunization and mother and neonatal child health. Expanding maternal or newborn policies and benefits, have it all fully integrated into the newborn healthcare packages. Increase the proportion of deliveries at health facilities or with skilled birth attendants with various mechanisms. Have clear policies that take the delivery, or that take the vaccination into the delivery rooms and optimize the vaccine products as well as logistics. Next slide. So in summary, we have a very strong tool in place. It should be made universally available to all newborn babies and infants, children, as for all the other antigens or vaccines and national immunization programs. And we need to do strong advocacy, particularly with mothers during their pregnancy antenatal care, that they should not only go to a healthcare facility for their own safety as well as baby safety to deliver there, and then let the healthcare workers, among the other aspects of newborn care, deliver the birth dose. Thank you very much.
Thank you, Dr. Sigurd-Rosso, very much for enlightening us, and really particularly that the vaccines is actually sensitive to freezing. So that's a really important point for logistics. So moving, I see that there's a very active posting of questions already, and I would remind the panelists to have a look at the Q&A site, but we will reply that a bit later in the session. So without further ado, I'd like to invite Rachel Halford, who is the president of the World Hepatitis Alliance, for which WHO is working very closely with. And she will talk about the perspectives from communities and also to let us know what the new stigma index on hepatitis B and C is. Over to you, Rachel.
Oh, sorry, I couldn't find my unmute there. Thank you, Dr. Gwynn, and thank you very much for inviting me to speak today. It is a privilege to be a part of this Southeast Asia World Hepatitis Day webinar. Let me just put this on slideshow. Okay, perfect. Okay, so today I'm going to speak to you about a little bit and provide you with a very small overview to our recent stigma survey, just an overview of our pilot. But first of all, I'm going to talk to you just a little bit about our World Hepatitis Day message. And as we've already heard from a few of the speakers, very good speakers, thank you very much, it's time for action. So in 2024, actually what I thought I might do is just very quickly remind everybody, just in case there's any attendees, what World Hepatitis Day is. So it's held on the 28th of July. I think everybody knows that yesterday. It's a day to raise awareness of viral hepatitis, one of the World Health Organization's officially mandated global public health days. And on this day, we aim to unite the global community to demand action from decision makers and to prioritize the elimination of viral hepatitis, one of the most deadly and neglected diseases. And really, I just wanted to add in there that, in 2024, hepatitis, a disease with vaccines and treatment, really should be a thing of the past. Yet it is, as we've already heard, one of the world's second deadliest viruses, claiming 1.3 million lives each year. And according to new research from WHO, the numbers are rising. In addition, the numbers of new cases are estimated at 6,000 per day. I think the reason for this situation remains the same as when I completed my hepatitis C treatment in 2007. Irrespective of a raft of tools available, disseminated by the World Health Organization, resources are not being mobilized, stigma and discrimination are not being addressed, and despite commitments by governments and institutions in 2016, millions are being left behind. So it really is time for action now. Data suggests that we only have a really small window of opportunity, perhaps even just 2 years between 2024 to 26, to get back on track if we are going to achieve the global goal to eliminate hepatitis by 2030. So there are many factors that contribute to this lack of action. As I've already said, that we already have all the tools we need to do this. But we know from results of the World Hepatitis, our first hepatitis stigma survey, that the extensive stigma and discrimination affects people living with hepatitis, that the stigma that they experience on a day-to-day life, workplaces and healthcare settings has a really significant impact. So I'm just going to take you through very briefly a little bit about the stigma survey. So the World Hepatitis Alliance, in collaboration with the European Centre of Disease for Prevention and Control, that's ECDC, and people living with hepatitis, work together to develop a survey to better understand the people living with hepatitis, the experience of stigma and discrimination. So the survey was piloted across 9 European countries, including Bulgaria, Croatia, Cyprus, Denmark, Germany, Portugal, Spain, you can all read it, Romania, and the United Kingdom. And I'm just going to actually just take you through a few slides with some of the results that we found. Oops. So what was people's experience? So we learned that stigma and discrimination has a really significant impact on the lives of people living with hepatitis and their willingness to access healthcare, with 34% of those with hepatitis C worried that they would be treated differently by healthcare professionals. 32% of people with hepatitis C had a delay in treatment or medical procedures, compared to 15% of those living with hepatitis B. I know from my own personal experience, when I had hepatitis C and it was still active, I had significant issues in accessing treatment from dentists. They always put me at the end of the queue, because they had such a lack of understanding around hepatitis C. So who have you told? So the impact on someone, you know, it's like, how comfortable do you feel being able to tell somebody about your diagnosis, about your status? So 46% of those people living with hepatitis B thought that it was really difficult to tell people that they were living with the virus. And even 24% hadn't even told their family. And this is really shocking, because, you know, we have to remember that, you know, transmission and safety. In terms of sexual relationships, stigma and discrimination is also experienced within sexual relationships, with 9% of those living with hepatitis B being threatened, verbally abused, or physically harmed by a sexual partner. And this, I mean, for me, this is just absolutely outrageous. This is absolute pure ignorance. So how does it feel living with viral hepatitis? So stigma and discrimination can cause emotional distress like depression and anxiety. 16% of people living with hepatitis C reported moderate levels of emotional distress, and 48% agreed that they had or have had really poor self-esteem because they were living with hepatitis C. 46% of those with hepatitis B agreed it's really difficult to tell people that I'm living with hepatitis. And I can't tell you that the impact of that constant pressure of knowing that you have a virus that you can't share and tell anybody about, it really does weigh very, very heavily on an individual. Finally, in terms of stigma and discrimination in professional life, and I think that we forget this one, it's very easy to forget this one, but 17% of those living with hepatitis C felt that they were treated unfairly at work. And really shockingly, 7% of those living with either hepatitis B or hepatitis C had either been denied employment or fired from their employment. So in terms of what are our key takeaways from this? You know, stigma and discrimination has a significant impact on the lives of people living with hepatitis. And it definitely, you know, we know from the results of the survey that we completed, it really does impact on their willingness to access services. So, you know, what are the key takeaways and maybe our next steps? I think it's really important to say that, you know, countries will not reach elimination without addressing stigma and discrimination. We need people to feel comfortable to access services. We need them to be able to come forward with confidence. So therefore, countries need to include, awareness raising activities with both key populations and general populations, so that people are not stigmatized due to misinformation and that they feel empowered to ask for testing and share their status with their families and partners. We really need to change the conversation. Really, seeing the slides from Dr. Vishnu, and the 75% of liver cancer is attributed to hepatitis. We really need to change this conversation so that there isn't the stigma, so that people are happy and willing to come forward and either access treatment or vaccination. We need education for healthcare workers and a commitment to ensure that healthcare settings are free from stigma so that people do not avoid or delay accessing treatment. And actually, we know from the UK that people with lived experience are really good. There's a fantastic resource at providing that education about, at changing the conversation and changing the message on the ground. All countries need really strong and anti-discriminatory laws to ensure that people with hepatitis are able to work, study, and travel. And I think that goes without saying. But central to all of this is meaningful engagement of people with lived experience in program design and delivery. And then just really importantly, moving forward, we will be releasing a full report of the pilot. So the data that I just showed, but also more, that will come out in the autumn. And our goal then moving forward is to expand the survey, roll it out across not just the rest of Europe, but the whole of the world. Thank you very much.
Thank you very much, Rachel. And this is a truly a marked step forwards to have a global stigma index for hepatitis B and C. And I hope that for the people who are listening in, step up, take action, reach out to the World Hepatitis Alliance to get involved in getting this stigma index off the ground in Asia. And that's where we bear a brunt of the hepatitis B and C, is in this region. So moving forward, we will now have a story from Mr. Shadab Hassan, who's a lived experience of hepatitis and being a survivor. So we will talk to the panel for Q&A later on after Mr. Shadab's story. And then after that, we'll see to move forwards. So, Mr. Shadab, over to you. Please tell us and share your experience.
Hello, everybody. Thank you, Dr. Paulin, for giving me a platform to tell my story and share it with everybody. Perhaps it can help all the stakeholders who have joined today to understand how they can help people like me. My story started in 2006. I was keeping unwell, and after a random test, a number of tests, I tested positive for hepatitis C, and it was like a bombshell for me. I was just 26. I just started a career. I was recently married, and now I get to know that I have hepatitis C. At that time, we did not have DAs. I was prescribed the PEG interferon therapy. It was expensive, around rupees 14,000 at that time per injection. And I took the 12 weeks therapy treatment, but I was unlucky. I had to bear all the side effects, and I was not cured. Things went really bad for me after that. In the next few years, I had already developed liver cirrhosis. I was vomiting 7 to 8 times a day. I was malnourished. I had all these symptoms of cirrhosis, ascites. My stomach was bloated. And finally, I slipped into a coma. And it's just that I was lucky that I had friends and family, who pulled in. And when I, opened my eyes, I came to know that they had all decided that I can get a liver transplant. My younger brother, who was just 18 at that time, he decided to donate a part of his liver. And yeah, so this was around 2010, I guess. And so I underwent the liver transplant. It was successful and everything was great for just 3-4 months. I was told again that there's something called hepatitis recurrence. My liver was also being attacked by the hepatitis virus, and the virus was more aggressive this time. I developed ascites in just a few months, and I was really not prepared to go through all of that again. And so during this time, I came to know that there are some trial drugs called DAAs, and Mr. Gitain from Amphar, I was really active online at this time, and he told me, you know what? There are some people called MSF Access, especially Lena from MSF Access. You should meet them. And I went and met Lena, and she told me, there is this something called the compassionate program for medicines, and we will do all the paperwork, and we'll try to help you to get access to these medicines, to these new medicines. And yeah, so it was really difficult to get access at that time, but because of these lovely people, I was able to get access to these drugs. And within 12 weeks, miracle happened, and the virus, I was cured, you could say. I did not have the virus anymore. And so I would just like to say, it's just that for people like me, it was always difficult to get access, in spite of these programs were being there and the medicines were being there, and I was not aware. So I guess people, more awareness need to happen, and people should know that these new drugs are there now. They are accessible. They should get tested and treated. And yeah, so that's about it. Thank you.
Thank you, Mr. Shadab. And it's a really powerful story, in the sense that you discovered that you were your status of hepatitis C infection. That was quite a long time ago, isn't it? It was around 2000 and 2006.
2006, that's right. Yes.
Yes. During that time, and I wanted to bring forward to what Rachel said about stigma discrimination. What were you asked by your friends and family?
Right. So it's a $1 million question. I'm even asked today, what did you do? How did you get the virus? How did that happen to you? I still get asked that question a lot. And, I have no answer for that. And I guess to anybody who has had hepatitis C, I would tell them, you don't even have to answer that question. It's not our burden. It's not our cross to bear, I guess.
Yes, I think that's really important now, because I get asked, because everybody wants to have a cause. And usually the first thing that, when someone has hepatitis C, the question that professionals and people and lay people say, are you injecting drug user? But hey, I would like to also bring to attention that hepatitis C, as with hepatitis B, is a blood-borne infection, and it can be transmitted by poor infection control, whether through medical settings or dental settings, or we have barbering barbering with poor infection control and reuse razors. These all happens as well. And in many countries, we see also that is actually not due to injecting drug use alone. Of course, those who inject will have a higher risk of injecting, but there are very many general lay people, men and women, who are transmitted because they ever had poor infection control in healthcare settings, whether dental or medical, a long time back. As a child, as an adolescent, as a teenager, when they go and they are taken by their parents to the to facilities. Of course, today it's much better. Infection prevention control is much better. But decades ago, this was still very, very challenging as well. And in fact, in the Southeast Asia region, we still continue in some countries to have issues with infection prevention and control in the different settings. But what is important now is this: hepatitis C is treatable, is curable. And the drugs is just a daily dose of drugs for 12 weeks with very little side effects. So, Mr. Shadab, congratulations, because you have survived the interferon therapy that was done decades ago.
Yes, I mean, it was really difficult to go through that, and then to, we talk about cirrhosis, but to understand to how it is to live with cirrhosis, it's a very painful. It was a very painful period for me and my family, especially my wife. I wish people get tested and they don't have to face this ever, because cirrhosis is really bad. It's very painful to live with.
And that's really a very powerful story. Thank you, Mr. Shadab. So we're now going to move on to questions and answers. But Rachel, just over back to you, because I see that you immediately showed yourself during this powerful story. Have you heard also stories such as this in your experience as well, as president of the World Hepatitis Alliance? Over to you.
Thank you. Yes, I have. And Mr. Shabdab, thank you so much for your for sharing your experience. This week for me is really difficult. My very best and dearest friend went through something very similar to you, and she didn't survive. She died 5 years ago, and I lived through a lot of with her. What you described, the ascites, going into a coma, and I think that that you cannot underestimate how horrific I saw it, and the fact that you're here today is, and telling your story today is just incredible, because it was heartbreaking to see my friend go through that. And it's senseless. There is a cure for hepatitis C. There are vaccines for hepatitis B. People don't need to be going through this, and it breaks my heart. I'm thrilled to see that you're sat here today telling your story, but it breaks my heart that so many people aren't, because these are needless deaths. They really are. And because it's just about that access to treatment, to DAAs. And like you say, whilst DAAs have been around since 2015, 2016, some people still don't know, and that is insane. And just to say, Pauline, that, I think in the Southeast Asian region, the majority of people affected by hepatitis C, it doesn't come through injecting drug use. It comes through, exactly as you say, kind of medical procedures or what was previously poor practice. And I think it's very much exactly as you say, Dr. Shabda, that it's about raising awareness. It's about changing the conversation. And I loved your answer around, when people ask you, how do you get it? And you say, well, I shouldn't have to say, we lived through COVID as a globe, as the whole global community. Nobody said, oh, where did you get your COVID from? Nobody went up and asked you. We just all accepted and just carried on and went through it. And I think it's the same with hepatitis. Doesn't matter where it came from. Let's just get the treatment. You know, so I love that answer. I think it's a brilliant answer. I don't think I've ever heard anybody say it before. I love that.
Thank
So
you.
thank you so much.
Thank you, Rachel. And over here, one of our participants, Mr. Gitton, said that in 2001, when the father was diagnosed with hepatitis C, the first question the doctor asked was, "How much money do you have?" He would have sold everything to get the dad treated. And yes, he got it from medical procedures during that time or before. So I have a question here from Dr. Leilani Rajapaksa. It's really moving forward to the Q&A now. Stigma in professional life. Were the respondents healthcare professionals, and do other professionals need to disclose hepatitis B and C status? This is probably referring to the stigma index. Over to you.
I think that differs and varies from country to country whether you have to disclose. I know in the UK, in theory, if you are in the healthcare profession, I think, you know, don't quote me on this, but I'm pretty sure that if you are a nurse or you are a clinician, you need to disclose. But there shouldn't be any stigma held against anybody. You know, I've heard from people who haven't disclosed. You know, they're very safe in their practice. And if you are fully trained and operating in a professional manner, it is no risk, you know, so, but there are different laws in different countries as to whether you have to disclose if you are working in a healthcare profession. But I do think that, you know, it comes back to the question that, you know, the questions that we asked. It's very much around raising awareness, because there is a lack of awareness. There's a lack of knowledge around transmission. There's a lack of knowledge around the impact of hepatitis, viral hepatitis. So it's around education. And I think, as I said, not just, you know, necessarily for that kind of legality around, do I have to disclose? But in terms of raising awareness, people with lived experience really are the best for helping for somebody to understand more about viral hepatitis. In the UK, we have a whole team of people with lived experience who go and they share their stories and they explain and train professionals on viral hepatitis, hepatitis B and hepatitis C. And the professionals hear it and understand it from that perspective then. But my message in terms of healthcare workers, and I'm sure there's somebody on the call that would know better than me, is that it varies from country to country. But my understanding is that you do have to disclose, yes.
Thank you very much. So for people on the participating, you can put your questions in the Q&A. So moving forwards to Dr. Bishnu Giri, Mr. Jimmy Singh Aramban actually put in a question, is that even when HCV is treated, is there a risk of liver cancer? So I thought that although you have answered it, it would be nice to really talk about that, because we're talking about liver cancer and hepatitis. Over to you.
Yep, as I answered in the Q&A section. So once hepatitis C is effectively treated, the risk of liver cancer because of hepatitis C is very highly reduced. It is significantly reduced. And if the patient has already developed cirrhosis, then there is a risk because of cirrhosis. Similarly, if there are other risk factors such as alcohol, tobacco, or steatohepatitis, then there is the risk of liver cancer prevails. But the point is, if hepatitis C is treated, the risk of developing liver cancer is highly reduced.
Thank you very much. And it was also mentioned earlier is that it will be important to try to catch people early before cirrhosis actually develops. Because once cirrhosis develops, you know, some of the livers might progress really quickly to different stages and later stages of cirrhosis. But if it's early, there's still a chance of reversing with treatment, whether for hepatitis B or for hepatitis C. It's really cirrhosis really is really linked very heavily with development of liver cancer. And this is really important to try to get people into care really earlier, much earlier. So thank you, Dr. Giri. So Dr. Sigrun, we have several questions for you. So perhaps we'll start from Dr. Subhash Lakhe, that in a country with low childhood hepatitis B prevalence of less than 1% and a high coverage of primary hepatitis B immunization coverage, what is the recommendation on introduction of birth dose to a country? So over to you. Dr. Sigrun, you're muted, so we can't hear you.
I apologize for that. I thought just pressing this one button would unmute. It's a very good question. I appreciate it because it shows how much everything has been taken in from the presentation and thought through. Even if a country has already proven that the seroprevalence in children is low and the infancy vaccination is high, we still need then to consider what is the seroprevalence in the adult population and particularly in pregnant women. Because it can very well be that women were born before the time that a successful immunization program targeting infants but not giving the birth dose were born. So we usually, as WHO, recommend that every country should have either a universal birth dose or should have at least a targeted birth dose when there is the respective screening of pregnant women, and then that mothers that test positive, that their babies at least get the timely birth dose and also immunoglobulin. So that is the general recommendation. Now for national programs to consider, in the scenario described, I would strongly recommend that a seroprevalence study has also been done in the adult population and particularly in pregnant women to see how high, how low the seroprevalence is there. Because even if it is a relatively small percentage for the individual mother and her unborn baby, any risk would be a very serious matter. What it also brings in, I'm not working in that area, but is the need for universal screening and testing of pregnant women so that infection of the mother could already be determined at that time. Thank you.
Thank you, Dr. Siggi, and to also to flag the area of prevention of mother-to-child transmission of hepatitis B, which is an addition and complementary intervention to the vaccination for baby and eventually for mother as well. So in 2020, WHO released the first ever guidelines on the use of antiviral drugs, tenofovir to be specific, for the prevention of mother-to-child transmission of hepatitis B. So generally, the guidelines state that, and of course in 2024, an update has occurred that to provide women who have high maternal viral load, more than 200,000 international units per mil, with if they have a hepatitis B E antigen positive, with tenofovir to further prevent the transmission of hepatitis B virus to their baby. And this is complementary to the use of hepatitis B immunoglobulin and also for the timely birth dose and the completion of at least 3 doses of hepatitis B vaccination to the baby. So, more, and for the participants is please go up to the website. The QR code that was originally presented earlier in the webinar has all these guidelines as well and can link you quickly there. So Dr. Sigrun, Mr. Gitton has also asked about sharing your thoughts around hepatitis B catch-up vaccination among key or high-risk groups of people who inject drugs, transgender people, men who have sex with men, etc., not only healthcare providers. of course, keeping aside chronicity of infection when exposed as an adult. So, so WHO has these recommendations since 2012 with updates continuously. And also US CDC has also updated these guidelines in 2022 for adults who want to have SEARO protection. So do you have any comment on this, how national programs may move forward on that? Thank you.
I hope I'm audible.
Yes.
Okay,
yes,
this time
please.
it works. Yeah, I also appreciate this question very much because it is highly relevant for the evolution of immunization programs. When we initially in the region advocated with countries and supporting partner organizations to give the universal hepatitis B vaccination, it was targeted on children, as I explained earlier, because it was just a limited pool of resources that was available. And as we have gone through it together, vaccinating babies, especially right after birth, it's a very good way of preventing infection, chronic infection. However, we should not neglect that, of course, high-risk groups, whatever way they are being defined by the hepatitis B experts in that regard, will also greatly benefit from vaccination. And as such, we are moving towards at least recommending it as a first step for healthcare workers, where there is not much of a control on a diverse point of view, that the risk status is there and the investment is very on the positive side. So our work is now focusing very much on encouraging countries to firstly establish a respective national policy, then the costing has to be done, the resources need to be identified, and then go ahead with it. However, I personally, because I'm not just an immunization public health specialist, but a medical doctor, I would strongly recommend that every country, every national program should also further identify high-risk groups, and when the respective screening, testing programs, and so on are in place, to also offer hepatitis B vaccination. Even if we say in general that in adulthood the risk of chronic infection is lower, but then high-risk groups, they bring in certain other risk factors. So I believe there will be a gradual shift towards, after healthcare workers are fully covered in countries in the region, to move also to other high-risk groups. And that should be fully supported if it would not take resources away from the critical childhood or newborn vaccination. As Dr. Pauline just said, that is our main intervention. We have to eliminate mother-to-child transmission as one of the beginnings of chronic infection. Thank you.
Thank you, Dr. Sigrun. We are almost up to the top of the hour for the webinar. And there's one question here from Mr. Sanjay Sharma on the hepatitis vaccination dose 016 and 012. What is the difference in immunity?
The first schedule should protect equally as the second one.
Okay, so so that would answer that question on the vaccination then. And the last one is Dr. Leilani Rajapaksa on tattoo parlors that are increasing with limited facilities. Practicing infection control measures may be an issue. Are there guidelines to regulate the practice in the Southeast Asia region? I will answer that because so as to my knowledge, no, there are no regulations that are from WHO to regulate the practice on Southeast Asia region, because tattooing is, of course, is one of the risks of having infections, bloodborne infections such as HIV, hepatitis B, and hepatitis C, especially if they draw blood. And it will be important for countries to look into this area of infection prevention and control broadly. It's not just about tattooing partners, it's also people for a whole range of businesses that have interventions that pierce through the skin and may cause a blood draw. So, but then again, very importantly is as today, healthcare facilities are much better. All countries have single-use syringes and much better infection control compared to a decade ago. Blood transfusions are safe now because they're all screened. So it will be really important to make sure that we continue attention to better infection control in the whole region. So we are in the last minute now, and I would like to invite all to thank and applause the superb lineup of speakers that we have today. We'd like to thank Dr. Suman Rijal, the Director of Communicable Disease of the WHO Regional Office of Southeast Asia, for opening the event. And also to Dr. Bishnu Giri, Dr. Sigrun Rosso, Rachel Halford from the World Hepatitis Alliance, Mr. Shadab Hassan for your powerful story. And well, to all, to have a very nice day. And if you can just show your video so that we can get a picture of it. Thank you, Eric. And thank you to the superb ECHO team that is with us today. If you can show your picture and your video so that we can all have a picture together. It is the World Hepatitis Day, and to celebrate this all together today. So Smriti, let us know when you're ready. I'd like to thank all the WHO country officers that have joined us for this webinar series. And I hope that you're having a good celebration also in your own countries. Thank you all. Thank you for attending and your attention during this webinar. Happy World Hepatitis Day. Bye.
Bye. Thank you.
Thank you.
Thank you.